Hello friends, welcome to the show Talk with Your Dog. My name is Dr.Prashant Jani. I am a physician here at Thunder Bay Regional Health Science Centre, Thunder Bay, Ontario, Canada, and I am also Associate Professor of Medicine at Northern Ontario School of Medicine, Thunder Bay, Ontario. Prostate cancer incidence is increasing day by day. The statistics say that 1 in 7 males will be diagnosed with prostate cancer in North America. After the skin cancer, the prostate cancer is the second most common type of cancer in males in North America. And it is also one of the most important factor which contributes to the cancer related deaths in males. After lung cancer, it is the second most cancer related death cause in males in North America. It is said that 1 in 39 males will die due to prostate cancer in North America. So we can see that prostate cancer is very significant in our community. And prostate, as you may know, that it is a very small gland which is situated just underneath the bladder, and it is part of male reproductive system, and it is in close correlation with the rectum, and the urethra which drains the urine from the bladder also passes through the prostate. So prostate is a very important organ in our body in the males, and the cancer of prostate is rising day by day. So today in this show we are going to talk about what are the risk factors of the prostate cancer, what are the early diagnostic methods, and what are the treatment options available at this time. With me is Dr. Walid Shahrour, who is a urologist at Thunder Bay Regional Health Science Centre in Thunder Bay, Ontario. Welcome, Dr. Shahrour, for today's show.
Thank you.
Thank you for your time. In my practice, every day I see quite a few cancer prostate biopsies which are positive for the cancer, and you might be seeing the many patients with the prostate cancer. What do you think, what are the possible risk factors which leads to the prostate cancer?
Well, there are many known risk factors. There are some of them that include, for example, the race. We know that, for example, if you are of African origin, you have higher risk of prostate cancer. If you're North American, like white, Caucasian,
yes,
higher risk of prostate cancer. We, like South American, have higher risk of prostate cancer. But we also see that if you're Asian, for example,
yes,
you have lower risk of prostate,
of
prostate cancer.
Yes.
That's one of the risk factors. Other risk factors would include like having family history.
Family history.
So if you have, like, let's say a father who had a prostate cancer, a brother who had prostate cancer, so these people who are, you would say, in like your immediate family, or like your brother, your father, they increase your risk. To a lesser degree, if you have, like, let's say cousins,
right,
it's not as high.
So it is a genetically linked, probably.
Well, there are some theories, and there are actually some genes which have been identified. We think they have a relationship with prostate cancer. There's the BRCA.
BRCA, yes.
So
it is the same as which is related with the breast cancer.
Exactly. Is it a very strong correlation? Well, there is a correlation, but it's not as strong maybe as the breast one.
Right.
There's also the HNPC, like the hereditary non-polyposis cancer. Basically, it also has a relationship to do with prostate cancer. These are genetic factors. We also can see some correlation between with age, like risk factors with age.
Age, yes.
So I always tell my patients, you know what, when you're 30, your chances of having prostate cancer are extremely rare, while when you get older, the older you get, the more the chance you're going to have prostate cancer.
Yes.
As a matter of like the prostate getting probably the constant exposure, with time it will eventually have.
So you think like it is rare before the 40 years of age, and it increases after the certain age?
Although we always say, you know what, if you want to think about the incidence of prostate cancer, you always think about it age. So if you have, like, let's say you're 40, there's 40%, but doesn't mean that this is a clinically significant cancer.
Right.
So we have to identify we have to make a difference between what is clinically significant and what is not significant.
Right.
Because if you take a prostate of a 50-year-old male who, let's say, passed away from some other cause than prostate cancer, and you do the do biopsy and you check like under the pathology with the
Yes.
pathologist, you will find like small focus of prostate cancer probably in 50% of these if you get 10 patients
Yes.
with the same age, you'll have 5 of them having
So
prostate cancer.
asymptomatic cancer will be there, but it won't be clinically significant.
Exactly.
Yes.
Exactly.
Do you think diet is related with the cancer?
That's one of the most common questions I always get asked. Like, oh, is there something in my diet? I can change something. There are theories behind it, but I have to say they are weak.
Okay.
So they think, for example, if you have high-fat diet,
yes,
this can increase
risk
your risk of prostate cancer. Although I have to say the science behind it is not that strong, so it's not really a way to say, oh yeah, you know what, this is a preventative method.
Okay.
To
I have read that maybe red meat diet is associated with the increased risk of prostate cancer, and people who eat less fruits and green vegetables have risk. What do you think about that?
Well, it goes, I think, under the same umbrella. You know, like, you know, if you're eating a lot of red meat, they think that, you know what, the studies have shown there's some correlation. But the thing is, it's very hard to pinpoint the cause. And and just because they're both happening, it doesn't mean it's a causative agent.
How about smoking exposure?
Smoking has been shown
is associated
to have
risk.
some, but it is not, for example, as strong as a correlation, for example, between smoking and bladder cancer or lung cancer.
Correct.
So
there is small risk increase.
There is a small risk, but it's not as strong as a correlation as other agents.
What do you think about the sexually transmitted diseases and prostatitis, infection of prostate? Do you think those are related with the prostate cancer?
It's a very weak correlation.
Okay.
There was actually in the past, there used to be like, vasectomy, for example, used to be one of the risk factors thought to be for prostate cancer. But right nowadays, there are many like publications coming out saying, you know what, it might not be the case. Okay. So whenever like if we have a very strong correlation, we know, like, for example, as we said, family history, this is a strong correlation and we can see it. But when then you go for the diet or exposure, there's some correlation, but it is not very strong. So it doesn't become as a strong evidence.
So what do you think, what causes the prostate cancer? Is that all these risk factors leads to some sort of genetic alteration in the cancer cells, prostate cells, leading to cancer cell formation?
That's $1 million question you're asking here, because you know whenever anyone tells me like, how did this happen? Like, you know what? We think it's from the DNA. We think it's basically like your DNA is basically how that's the coding, how we are coded.
Right.
And if there's a problem with the coding, after a while, it basically leads to the cells becoming abnormal. I tell the patient the cells become crazy.
Right.
And they start like multiplying in a crazy way. But this is the theory behind it. Some people say, oh, you know what, it's just the age. With age, you get some, it's not like that you're inheriting the DNA, it's just a damage in the DNA. So it's rather than inheritance, it's more of an insult that happens. And then because of this insult that happens to the DNA, then you start developing the cancer. These are two theories behind it.
Thank you for explaining that. We'll take a short break and we'll come back to the next part, how to prevent and diagnose the cancer at early stage. Please come back. Welcome back to the show, Talk with Your Doc, and with me is Dr. Walid Shahrour. He is a urologist at Thunder Bay Regional Health Science Center, and we are talking about prostate cancer. We talked about various causes and the risk factors for the prostate cancer. Are there any lifestyle modifying factors or any medications which we can use it to reduce the risk of prostate cancer?
We always think that having a healthy lifestyle is always important. Patients who are, for example, obese, we think that they have higher chance of having prostate cancer. But we always think that, okay, you know what, if you go for a healthy diet, healthy exercise, this can actually might decrease the chances. Some people say, you know what, maybe because you're a health oriented person, you're checking your health better, and that's why you're probably like, you know, you're checking and maybe you're having less incidence, or maybe you're preventing it somehow from the exercise. But there's some evidence, but it's not as strong as we would want.
How about any medications or any drugs which are available in the market which can reduce the incidence of or risk of prostate cancer? Are there any?
So there used to be the idea before that taking vitamin like vitamin E or selenium, like that this would decrease the risk of prostate cancer. As I said, like before as well, with this, it's not a very strong evidence.
Right.
If you want to take it, it doesn't hurt, but it is not the sole preventive method. Some people thought of of aspirin.
Right.
It has been shown in some research that there's decreased incidence, but still there is no science behind it as much as we would want.
How about 5-alpha reductase inhibitor drugs which are available in the market? Do you think those reduce the incidence of prostate cancer?
That's a very good question. So 5-alpha reductase basically is a medication that blocks the conversion of testosterone in the prostate. So it's actually a medication that we give for patients who have benign prostatic hyperplasia or an enlarged prostate. It shrinks the prostate.
Prostate, right.
It takes few months to start having an action. And people were thinking, okay, if it's actually shrinking the prostate, maybe it could have an effect on the cancer.
Cancer, right.
So there were studies, and big studies actually, very large studies done, and they were looking at what if we give this family of medication to the patients and see how they do. After some time, then they were basically checking, doing biopsies, and they found that there is an absolute reduction in the incidence of prostate cancer when you give this medication.
Okay.
Then they did further studies on in the same research that they were doing. They found that there was increased incidence of higher grade prostate cancer on patients who are taking this medication.
Okay.
So then it became basically a dilemma, and the people were like, okay, so now we should not give it because it's giving higher chance of higher grade cancer.
Right.
Then further analysis has been done. People are saying, you know what, maybe it's because we're shrinking the prostate. Then when we are doing biopsies for these patients, we're catching more disease because now it's easier to catch the cancer because now the concentration is basically more evident because now the prostate is smaller. Right. So it has some preventive methods, but it is not really
so
a way to...
it is not routinely used in practice?
It is not used. Like I would not give it to my patient and say, okay, you know what, I'm giving you this medication to prevent cancer for you.
Okay, so that's not used, right. So how a patient with a prostate cancer present, what are the signs and symptoms of prostate cancer? If one has a prostate cancer or not, how can we come to know?
That's a hard question because you know what? It's a silent killer.
Okay.
We can't tell. I tell the patient, you know what? We can't, like signs and symptoms, you might have no sign or symptom until later on. Sometimes they present to me with with symptoms of problems with urination, hard time initiating urine, like intermittency, incomplete emptying of their bladder, weak stream, but these are also symptoms of benign prostatic hyperplasia.
Right, so it's confusing.
So it's confusing. So usually to diagnose it, it basically comes from rectal exam and doing a blood test.
Investigations,
exactly.
Right? So, a lot of people do the PSA blood test, prostate specific antigen test, and there are set levels. We as a pathologist, we issue quite a few report of prostate specific antigen report. So, can you please tell us correlation between the level of PSA, what is PSA, and how one can get that test done? So,
to understand PSA first, we need to understand what it is. It's a protein produced by the prostate.
Right.
So I have a PSA, you have a PSA, anyone who has a prostate usually
everybody has a PSA in their blood.
And it can go up and down because of anything.
Right.
It's not very specific to cancer.
Right.
It can go up because of infection, instrumentation. You have had you have a large prostate in general.
Right.
So whenever we talk about prostate cancer and PSA, we have to identify the acceptable level and to correlate it with other parameters.
So what is the cutoff level?
We always say it's 4.
4 nanograms.
And now people are going more towards 3.
3. Oh, it's even lower.
It's even getting lower now.
Right.
Because depending on age. So there is 4 is not just a number.
Yeah.
Because if you are 70 and your PSA is 4, most likely it's a very good PSA because also we have to correlate it with age and prostate size.
Right. So 4 to 10 they say increased risk, and more than 10 they say it's more than 50% of patients with 10 or more PSA will have cancer. So what next then? Once the PSA is higher, then what do you advise to the patients?
So PSA, we don't take it only in one shot, like we don't take it just one number, we have to see a pattern.
Okay.
So because sometimes maybe this time it's 10, next time it's 5, because it was not there was some inflammation happening, there's something happening in his body, in the patient's body that caused the PSA to go high. So we have to get a pattern. And once we see the pattern, there are also other parameters. We see the free amount of PSA to the total amount of PSA, and we see there is a ratio. Sometimes if this ratio is too high, then we think it's okay. If it's too low, maybe it's actually having a higher indication of cancer. So we also divide PSA less than 10, it's lower risk. Above, between 10 and 20, it's intermediate risk. Above 20 is higher risk of prostate cancer.
So once you have a PSA high level and the pattern is high, then you might do prostate needle biopsies, and you send it to us as a pathologist, and we report the prostate needle biopsies by taking how many cores are there, what is the percentage of cancer in prostate needle biopsies, and what is the grade of Gleason scoring of the prostate cancer. And it is said that higher is the Gleason score, worst is the prognosis, or aggressive is the prostate cancer. So what do you do when you find higher Gleason score? What next investigation do you do after the prostate needle biopsy is done?
It all depends. Basically, if the patient, depends on my rectal exam and the PSA. So if I have a patient who I'm like having a very high PSA, let's say PSA comes back at 50, I probably would want to check if there is any disease outside. So sometimes we ask for a CT scan to check if there is any cancer outside, or we also get a bone scan to check if the prostate cancer has gone into the bones, because this is a very high level. It's always a multidisciplinary approach between the urologist, the pathologist, the oncologist, radiation oncologist. So it's a whole team that decides together what's going to be the best next step.
So first is digital rectal examination, then is the PSA, then you might do the biopsy, and if that is positive, you do the radiological investigation to see the extent, and then the treatment.
Exactly, if needed. That's exactly it.
So thank you for that. We'll take a short pause, and we'll come back with the next part of prostate cancer. We'll talk about the treatments in prostate cancer. Thank you, Dr. Shahrour.
Thank you.
Dear friends, welcome back to the Talk with Your Doc show. We have Dr. Walid here. He's a urologist at Thunderbay Regional Health Science Center. Thank you, Dr. Walid, and you have enlightened us about various risk factors for the prostate cancer and various investigations for the prostate cancer. What is the survival rate of the prostate cancer once one is diagnosed with the prostate cancer?
I have to say it's quite good. I always tell the patient, you know what, you don't have to start worrying about anything for now. It's a slow disease. It's a very slow disease. And usually I tell the patients, most of the time you outlive the cancer. So like 5-year survival is almost 100%. And then if you go like for 10 years, like 97, 98%, and same like for 15 years it goes a bit lower than that. But also it all depends on the grading of the stage of the disease. So if you're coming in with like an end stage disease, because of the late diagnosis, probably your 5-year survival will be way less than someone who's just coming in with the initial investigation because of a high PSA.
So prostate cancer has a good survival rate, almost 100% for the 5 years and more even further. Now, what are the treatment options for the patients with the prostate cancer? I mean, we have read and heard about watchful surveillance, surgery, chemotherapy, radiotherapy, hormonal therapy, and new vaccine available. So can you please tell us about the watchful follow-up or careful follow-up or active surveillance? Can you please tell us who is eligible for it?
So we have two different entities. One is watchful waiting and the other one is active surveillance. Watchful waiting means we just do nothing. And this basically becomes a decision between the patient and the doctor. Let's say the patient doesn't want anything to be done at all, and they say, you know what, I will do nothing. If I start having symptoms, I want you to treat the symptoms. So we're not treating the cancer. So
watchful waiting means patient can decide or doctor can recommend that this is option?
It's a discussion between the patient and the doctor. Active surveillance means someone is having a low risk disease. Like they have prostate cancer, but it's a low risk prostate cancer. It means it's a Gleason score of 6, for example, out of 10. And small amount, only 2 cores from the 6 biopsies or the 8 biopsies. And this, we tell them, okay, we're going to follow up on your PSA, rectal exam, and if we see there is progression, then we can start treatment. So basically, you're delaying treatment if till the point that there is progression.
Right.
Until that point, you don't do anything, but you're just you're following the patient, which is different from the watchful waiting where you do nothing.
Okay. So watchful waiting or active surveillance, what are the advantages of this treatment and what are the disadvantages?
So for watchful waiting, there was a study done, it's called the Scandinavian study, and it has shown that patients who are doing watchful waiting usually don't do as well. Because they basically come back when it's too late to has progressed too much, and becomes a hard thing to treat. While active surveillance, it is recommended for patients who are basically are going to be following the rules and coming to the follow-ups. For patients with low-grade cancer and small amount of disease, then we do the active surveillance to see.
So advantages is that you can avoid the side effects of the radical surgery, right?
You're avoiding, we are waiting, and you're waiting to see if maybe your disease does not progress.
Yes.
And you'll avoid having a strong surgery, like a big surgery, or radiation therapy, or hormones, or
So those are the advantages of active surveillance.
Exactly.
When disadvantage can be like the disease may progress.
It might progress if you're not following it closely.
Yes.
You might miss the boat.
Right.
And anxiety for the patient. Some patients, they say, I cannot live knowing that I have a cancer.
Right.
While others say, you know what, I'm fine as long as I know that I'm controlling it.
Right. Now, so suppose patient decides that he wants to go for a surgery and not active surveillance or watchful waiting. So what are the surgical options available for them?
So the surgical options would include the main thing is radical prostatectomy, which can be done in different ways. It can be done by open approach.
Right.
It can be done laparoscopically and robotically.
Right.
These are the different ways of doing it. It's one of the most common procedures done in urology, and it has good outcomes, but also it has problems.
Right.
As any surgery in life, surgery doesn't come for free.
Right.
It has complications.
Risk factors. Yes.
Exactly. So patients can have bleeding, infection from the operation. They can lose their erections because the nerves are running on the sides of the prostate, and we do sometimes nerve sparing, but sometimes we can because of the cancer. They can get some incontinence.
Incontinence is one of the most common concern for many patients. Does this incontinence, which is caused, which is nothing but ability to control the flow of the urine, does it come back after some months or some weeks back to the patient?
So for sure it can come back. It all depends on how, it has a good correlation with the surgical approach and the surgical experience of the surgeon. It can come back. Usually we tell them to do Kegel exercises, and in few months some patients gain full control. Sometimes they have some small amount of incontinence, but they can actually...
So incontinence can come back and the lifestyle can be better, actually.
For sure.
It's not going to be worse.
And if it is a refractory problem, then we can sometimes put sphincters in these patients.
Right. Now, other than the surgery, I have seen many patients being treated with the radiation treatment. And is the radiation first line of treatment if it is a low-grade cancer, or do you treat the patients after the surgery with radiation? How do you do that?
So it all depends on the disease and the extent of the disease and the age and the patient's preference. Some patients don't want surgery; they want to go for radiation. So radiation is it can be first line for sure. It's not only surgery. Radiation can be first line, especially for lower grade of cancer, and even in the higher grades of cancer where we think we cannot, with the surgery alone is not going to be controlling. So sometimes we just do the surgery. We do the radiation, thinking that it would give us a good control.
So low-grade cancer, which can be treated just with radiation, or the cancer which has spread and it is very difficult to treat with surgery, we can treat with the radiation.
Exactly.
So the radiations can be external beam, and there is the brachytherapy,
which is basically we implant certain like small implants in the prostate, and this actually emits the radiation and kills. So sometimes we even do combined approach between the brachytherapy and the external beam from outside.
Oh, wonderful. Now, other than this chemotherapy, other than the radiation therapy, can you please tell us about hormonal therapy and chemotherapy?
So hormonal therapy goes on the theory that we give hormones to block the testosterone, and if we block the testosterone, we can actually get the cancer to be to shrink and to stop growing.
Right. So there are medications available?
There are medications. We have medications that blocks the testosterone itself, and we have medication that blocks the production of testosterone. So there are the many different types of medication that we can use, and the problem, like the side effects of these medication, they can, like, you get weaker, like, as if you're going through andropause. You don't have any more testosterone, so the muscle weakness, the person can age, and they have high correlation with cardiac disease as well.
So this hormonal treatment will not cure the patient, but it will reduce the progress of the cancer?
It's basically, I'm putting a hold
on the cancer, right?
As much as I can. Sometimes then the cancer develops ways to bypass this blockage.
Okay.
And they start reproducing again. Then we can go for the chemotherapy.
Chemotherapy, yes.
Chemotherapy, or there is even now newer drugs also taking care of hormones, but on a stronger level. There's a drug called abiraterone. There's another drug called enzalutamide. They're like complete blockade, very strong medications and they're gaining popularity. As well as the non-conventional chemotherapy, which is usually in the castrate resistant, when the patient when the hormones are not doing enough to stop the cancer, then we can give chemotherapy in cases where the cancer has spread.
Okay. Can you please briefly tell about the vaccine for the prostate cancer? We have heard about the vaccine. So what is the vaccine and how to use it?
So the vaccine, basically, it's Suplusil. It's a vaccine for the patient where we take the cancer cells and we develop a vaccine against it. So we induce the immunity of the patient. So we're not giving you things to kill the cancer. We're giving you actually a killed cancer to induce the immunity to kill, that your own immunity goes and fight the cancer. This is only in cases where it's not first line or second line. This is right now it's for the end stage cases for now. So in the future, probably with further research, this can. So
it's not a vaccine like we have a vaccine for other diseases where you inject the vaccine and you won't get the disease. This is a sort of a vaccine which will help you to boost your immunity to fight against the cancer.
Exactly. The cancer is there and you're trying to fight it more.
That's good. A lot of information you have given us today about the prostate cancer. Thank you, Dr. Walid.
Thank you.
Thank you so much for coming and participating here. We really appreciate it.
Pleasure.
Thank you for all the viewers for being part of Talk with Your Doc. We will come with you with the next show with the colon cancer and its diseases. Thank you.